Welcome to our deep dive into Osteitis condensans Ilii, or OCI, a rare, often misunderstood cause of lower back pain. OCI is a benign, self-limiting condition that primarily affects the iliac part of the sacroiliac joints. While its exact cause remains unknown, it is most commonly seen in women, especially after childbirth. Many people with OCI are asymptomatic, but some experience chronic, intermittent back pain. Today, we'll explore a real-life case, discuss the clinical features, diagnosis, and management, and help you understand why OCI should be considered in certain cases of persistent back pain. Let's begin by understanding what makes OCI unique. Osteitis condensans Ilii, also known as hyperostosis triangularis Ilii, is characterized by a triangular area of increased bone density, or sclerosis, on the ilium next to the sacroiliac joint. Unlike other joint disorders, OCI does not involve inflammation or joint space narrowing. It is often discovered incidentally on X-rays, as many patients do not have symptoms. However, when symptoms do occur, they usually manifest as chronic lower back pain, sometimes radiating to the hips or thighs. The condition is non-progressive and does not typically lead to long-term disability. OCI is a rare condition, but it is most frequently seen in women, particularly those who have recently given birth. The reason for this gender and postpartum predominance is not fully understood, but mechanical stress and hormonal changes during pregnancy are thought to play a role. Although OCI can also occur in men and women who have never been pregnant, these cases are less common. Understanding the epidemiology helps clinicians consider OCI in the differential diagnosis of chronic back pain, especially in women of reproductive age. Let's look at a real case. A 47-year-old woman presented with a decade-long history of intermittent lower back pain. Her pain was centered in the lower back and sacroiliac area, sometimes radiating to the upper thighs, and worsened with exertion or bending forward. The pain was mild, relieved by rest, and more severe during menstruation. She had no history of trauma, significant comorbidities, or family history of joint disease. Her symptoms began 1 year after her last pregnancy, highlighting the typical demographic and clinical presentation of OCI. Examination: the patient showed exaggerated lumbar lordosis and mild tenderness at the L4 and L5 vertebrae. There was no tenderness over the sacroiliac joints, and her hip joints were normal except for mild tenderness on the posterior aspect of both greater trochanters. Her spinal movements were full and painless, and chest expansion was normal. Diagnostic tests for sacroiliac joint involvement, such as the Faber test and pelvic compression, were negative. These findings suggested a chronic lumbosacral strain with bilateral sacroiliac arthralgia, but further imaging was needed for a definitive diagnosis. An X-ray of the pelvis revealed sclerosis of the iliac part of the sacroiliac joints without any erosion, irregularity, or fusion. This classic radiographic appearance is a hallmark of OCI. The lateral aspect of the greater trochanter showed slight irregularity, more pronounced on the right side, but no abnormalities were seen in the lumbar spine or hip joints. These imaging findings confirmed the diagnosis of Osteitis condensans Ilii, distinguishing it from other causes of back pain, such as spondyloarthropathy or osteoarthritis. Magnetic resonance imaging, MRI, provided further confirmation, showing focal sclerosis on the iliac aspect of both sacroiliac joints. Additionally, there was evidence of a posterocentral annular tear with a diffuse disc bulge, but no nerve root impingement. MRI is especially useful in differentiating OCI from other inflammatory or degenerative conditions, as it can reveal subtle changes in bone structure and rule out other pathologies. This imaging step is crucial when clinical suspicion remains after initial X-rays. Laboratory investigations in this case were largely unremarkable. Blood counts, erythrocyte sedimentation rate, ESR, rheumatoid factor, and HLA-B27 were all within normal limits. The absence of elevated inflammatory markers and negative autoimmune tests further supported the diagnosis of OCI, as opposed to inflammatory arthritis or ankylosing spondylitis. These normal lab results are typical in OCI and help to reassure both clinicians and patients about the benign nature of the condition. OCI must be differentiated from other causes of chronic back pain, such as spondyloarthropathy, osteoarthritis, and low-grade infective arthritis. Unlike these conditions, OCI does not involve joint space narrowing, erosions, or significant laboratory abnormalities. The clinical presentation can be similar, but imaging and lab findings are key to making the correct diagnosis. This distinction is important to avoid unnecessary treatments and to provide appropriate reassurance to the patient. Exact cause of OCI remains unknown, but mechanical stress across the sacroiliac joints is believed to play a significant role. During pregnancy, hormonal changes soften pelvic ligaments, increasing strain on the sacroiliac region. The ilium responds to this stress with bony thickening, visible as sclerosis on imaging. This process is non-inflammatory and does not progress to joint destruction. Understanding the pathophysiology helps explain why OCI is more common in postpartum women and why it is self-limiting. Most patients with OCI are asymptomatic, but when symptoms do occur, they typically include chronic, intermittent lower back pain. The pain may be mild to moderate, worsens with exertion or SIRT movements, and is often relieved by rest. Some patients experience pain radiating to the buttocks or thighs, and in women, symptoms may intensify during menstruation. Importantly, OCI does not cause morning stiffness or significant limitation of movement, distinguishing it from inflammatory conditions. Physical examination, findings may be subtle. There may be mild tenderness over the lower lumbar spine or greater trochanters, but sacroiliac joint tenderness is often absent. Spinal movements are typically full and painless, and provocative tests for sacroiliac joint involvement, such as the Faber test, are usually negative. These examination findings, combined with the patient's history and imaging, help narrow down the diagnosis to OCI. Hallmark of OCI on X-ray is triangular-shaped sclerosis on the iliac side of the sacroiliac joint, without joint space narrowing, erosions, or fusion. These changes are usually bilateral, but can be asymmetric. The rest of the pelvis and lumbar spine are typically normal. Recognizing these radiographic features is essential for making the diagnosis and avoiding confusion with other joint diseases. MRI is a valuable tool for confirming OCI and ruling out other causes of back pain. It can detect subtle sclerosis and exclude inflammatory or degenerative changes in the sacroiliac joints and spine. In this case, MRI showed focal sclerosis on both iliac aspects and a disc bulge at L4-L5, but no nerve root impingement. Advanced imaging is especially helpful when the diagnosis is uncertain or when other conditions are suspected. Laboratory tests in OCI are typically normal. Inflammatory markers such as ESR and C-reactive protein, CRP, are not elevated, and autoimmune markers like rheumatoid factor and HLA-B27 are negative. This normal lab profile helps distinguish OCI from inflammatory arthritis, which often present with abnormal laboratory findings. In our case, all blood investigations were within normal limits, supporting the diagnosis of a non-inflammatory, self-limiting disorder. Management of OCI is conservative. Most patients respond well to nonsteroidal anti-inflammatory drugs, NSAIDs, physical therapy, and rest. Education and reassurance about the benign, self-limiting nature of the condition are crucial. Surgery is rarely needed, and invasive treatments are reserved for refractory cases. The main goals are to reduce pain, improve function, and enhance quality of life. Physical therapy plays a central role in managing OCI. Exercises focusing on back extension, abdominal muscle strengthening, and general mobility help reduce pain and prevent recurrence. In our case, the patient was taught specific exercises for the back, limbs, neck, and chest, which contributed to her improvement. Regular follow-up and adherence to the exercise regimen are important for long-term success. Medications for OCI are primarily aimed at symptom relief. NSAIDs are commonly prescribed to manage pain and inflammation, even though OCI is not an inflammatory condition. In this case, the patient was also given calcium and vitamin D supplements to support bone health. Long-term medication is usually not necessary, and most patients can taper off as symptoms improve. Prognosis for OCI is excellent. The condition is self-limiting and does not progress to joint destruction or disability. Most patients experience significant improvement with conservative management, and surgery is rarely required. Regular follow-up ensures that symptoms are controlled and that no other underlying conditions are missed. Patients can be reassured about the benign nature of OCI. In our featured case, the patient responded well to conservative treatment. After 1 year of follow-up, she was pain-free in the sacroiliac area and only occasionally experienced mild midline lower back pain. This positive outcome highlights the effectiveness of non-invasive management and the importance of patient education and adherence to therapy. Clinicians should suspect OCI in women of reproductive age who present with chronic non-inflammatory lower back pain, especially if symptoms began after pregnancy. The absence of morning stiffness, normal laboratory findings, and characteristic imaging features help differentiate OCI from other causes. Early recognition prevents unnecessary investigations and treatments. OCI is often confused with more serious conditions like ankylosing spondylitis or osteoarthritis. However, the lack of joint space narrowing, erosions, or abnormal lab findings should prompt clinicians to consider OCI. Accurate diagnosis avoids unnecessary medications and invasive procedures, ensuring patients receive appropriate, conservative care. Imaging is central to diagnosing OCI. X-rays reveal the classic triangular sclerosis, while MRI and CT scans can provide additional detail and rule out other conditions. Imaging not only confirms the diagnosis, but also reassures both patient and clinician about the benign nature of the disease. Regular imaging follow-up is rarely needed unless symptoms change. Educating patients about OCI is vital. Explaining the self-limiting nature, excellent prognosis, and low risk of progression helps reduce anxiety and encourages adherence to conservative management. Patients should be informed about the importance of exercise, medication adherence, and regular follow-up, but also reassured that surgery is rarely needed. OCI has been described in medical literature since 1926, with numerous case reports and reviews highlighting its clinical features and management. While rare, increased awareness among clinicians has led to better recognition and outcomes for patients. Ongoing research continues to explore the underlying mechanisms and optimal management strategies for OCI. Summarize, Osteitis condensans ilii is a rare, benign cause of chronic lower back pain, most commonly affecting women after childbirth. It is characterized by triangular sclerosis on the iliac side of the sacroiliac joint, normal laboratory findings, and a self-limiting course. Conservative management with NSAIDs, physical therapy, and reassurance is usually effective, and the prognosis is excellent. If you or someone you know is experiencing chronic lower back pain, especially after pregnancy, and imaging shows characteristic changes, OCI should be considered. Remember, most cases resolve with conservative treatment, and the outlook is very positive. Awareness and early diagnosis are key to effective management and patient reassurance. As research continues, our understanding of OCI will improve. Future studies may uncover more about its pathogenesis, risk factors, and optimal management. For now, clinicians should remain vigilant and include OCI in the differential diagnosis of chronic back pain, especially in women of reproductive age. We acknowledge the contributions of the clinicians and researchers who have advanced our understanding of OCI. Their work has helped countless patients receive accurate diagnoses and effective treatment. Continued collaboration and knowledge sharing are essential for improving outcomes in rare conditions like OCI. Osteitis condensans ilii is a rare but important cause of chronic lower back pain, especially in women after childbirth. Early recognition, appropriate imaging, and conservative management are the cornerstones of care. With a benign course and excellent prognosis, patients can be reassured and supported through education and therapy. Thank you for joining us on this exploration of OCI.